Welcome to AETCM, the Emergency Medicine Channel. So shall we start? Today, we received a 66-year-old male to the ER with acute breathing difficulties. On the initial primary assessment, the patient was having he is not able to talk in one full sentence, but there were no secretions collected and pooled in the mouth, and the trachea was located centrally, sir. And then coming to the breathing, the patient was having 88% saturation at room air, and he was using severely using the accessory muscles for the respiration, and respiratory rate was 36 per minute. On auscultation, there was bilateral, there was reduced breath sounds bilaterally with the mild wheeze, audible wheeze was present, sir. Then at this point, because of saturation being 88%, we asked for connecting face mask with 10-liter oxygen and started with nebulization as there is a mild wheeze.
So this patient, as you told, the patient came with a sudden breathing difficulty. Patient is having airways patent, no secretions, no foreign bodies, but having very difficulty to talk, can't speak in a sentence, right? He speaks in words, phrases. Okay, so that shows that airway as such is clear, but patient is in respiratory distress. Coming to your breathing part, you told us accessory muscle use is there, respiratory rate is 36, saturation is 88. This is respiratory distress. Fine. So you started 10-liter oxygen, right? 10-liter oxygen. What is the current, or what is your aim? What is the oxygenation aim you are achieving to achieve here?
To improve the saturation.
Of course, that is a plan. Question is how much? How much do you want the SpO2 to be?
More than 94%.
More than 92 to 94%. That is the plan. We don't want 100% oxygen, right? Yes. So this patient right now in room air is having 88. That is 21% FiO2. He is having 88%. So we can start the patient on supplemental oxygen therapy. What you said is correct. But when you said 10 liter, what is the oxygen delivery device you are going to use?
Face mask.
No. You can't use face mask for 10 liter oxygen.
4 to 8.
4 to 8.
Face mask delivery would be from 4 liters to 8 liters.
Yeah, so when you say 10 liters, face mask is out of question, right? You can't use face mask there. What are you going to use? Yes, you are going to use a non-rebreathing mask. So non-rebreathing mask is what we use to give any percentage of oxygen more than 8 to 10 liters. Anything more than 10 liters, NRBM is a must. So if you are going to do that, what is the achievable PaO2 or achievable FiO2 with NRBM? What is the maximum FiO2 that is deliverable?
Maximum would be 60.
70 to 75% is the maximum achievable FiO2 with NRBM. So do we want that in this patient? No. He's having 88 on room air, right? So let's start supplemental oxygen maybe by 2 to 3 liters in a nasal bronch. Maximum put a face mask with 5 liter oxygen. That's the maximum level, because we will assess how he responds. Okay? He's on. What if he is a COPD patient? What if he is a COPD patient? You start on 10 liter oxygen, his PaO2 hikes up, his respiratory drive decreases. Does it make sense, right? So, acute breathing difficulty patient, it's especially a elderly patient coming, we don't know what is the cause of acute exacerbation. It can be multiple conditions. One of them is COPD. So don't flush the patient with oxygen. Start slow. Patient not improving, we can always hike it up. ABCD is not like one time, no? You do ABCD, then you reassess ABCD, isn't it? Okay. Yes. So ideally, nasal bronchs, 3 liters, 2 to 3 liters, we'll start. Then we'll observe. Then what else can you start here? Right now, what else can you start? Yes, NIV is a
directly NIV
option here. But what is his presentation? His presentation is respiratory distress. And Dr. Naveen is clearly telling that he is hearing wheeze. So we know there is bronchospasm. We don't want to wait till our primary survey to finish to start on a bronchodilator. We can start bronchodilator then and there itself. Isn't it? So oxygen delivery device with nasal bronchs start on nebulization. So if you are going to use nebulizer, then the question is, are you going to use nebulization without oxygen or with use? Basically with a nebulizer, or are you going to give with supplemental oxygen? So if your institution has nebulizer, it's ideal to give oxygen through nasal bronchs, 2 liters, and use nebulizer to give nebulization, so that patient will not have hyperoxemia. Okay. But if you are working in a system where you do not have access to a nebulizer, then it's better to start on nebulization mask with 4 to 5 liters of oxygen with a beta agonist drug, isn't it? Yeah. So we can start oxygen there and a bronchodilator there. This is the primary intervention we are going to do here.
In the breathing pain.
Yes. Then what?
Then next coming to the circulation.
Before coming to circulation, this patient, we already established he is in respiratory distress. Is there anything else at this point you need to look into which will tell you that this patient is in impending respiratory failure? There is something known as impending respiratory failure, right? Yes. Patient is not in respiratory failure but on the way. So how can you identify that kind of a patient?
Breath sounds.
Breath sounds possible, but what in breath sounds? Altered? Yes, altered sensorium. So this patient, bystander tells us this patient was fully conscious oriented, and now you are having a patient who is having a decreased sensorium, altered sensorium. You should suspect impending failure, because that shows severe hypoxemia to the brain, isn't it? Okay, what else? Cyanosis. Peripheral and central cyanosis means that patient is in severely hypoxemic, and you should most probably will require NIV or even invasive ventilation. What else?
Bradycardia.
Bradycardia can be there, but elderly patients present with bradycardia, we should always first think about beta blocker or a calcium channel blocker with the patient is taking. So do not always attribute bradycardias to pathologies. It can be secondary to the drug interaction too. What else? What is the saturation level in which we have to be a bit afraid of?
Saturation below 94%.
So according, if you take guidelines, IDSA guidelines or American guidelines and all, saturation in room air less than 90% is a criteria for severe acute exacerbation of asthma, severe acute exacerbation of asthma. On room air less than 90%. So he is having 88%. COPD varies, but we can suspect this patient to be in severe category. But if his saturation is less than 80%, we should be highly suspicious that patient is going into impending failure, because saturation less than 80% and all, that means that we have to understand the oxygen dissociation curve, and saturation and PaO2 doesn't have a linear relation. It has a sigmoid curve relation. So a rapid fall in PaO2 can happen even with small difference in SpO2. So less than 80, we should suspect patient is highly hypoxemic, and we can suspect that he might recur. Okay. Then what else? Any investigations you want to do to this patient right now? Yes, this is a patient you should have a ABG right now. What in ABG are you looking for?
We are looking for carbon dioxide retention and oxygen PaO2.
Yeah. Basically, you want to say whether the patient is in type 1 failure, hypoxemic, or type 2 failure, hypercapnic. This is the 2 criteria you are interested to know this patient. And of course, ABG will also give us bicarb. If you see a increase of bicarbonate in this patient, you can say this patient most probably will be a COPD patient, because there will be a compensatory changes. Even if CO2 of this patient will be
Normal.
normal or near normal. This patient presenting to emergency medicine, even in normal CO2, we have to, in COPD, it can present as normal CO2 itself because patient is already tachypnic. There will be CO2 washout. Okay, so CO2 is important and PaO2 is important and pH levels. Because if it is type 2, patient will be going into acute respiratory acidosis. These are the main three things that we are looking here: pH, PaO2, PCO2, isn't it? So you should order a
AB, arterial blood gas.
arterial blood gas at that point. Then coming to circulation.
So coming to circulation, patient is tachycardic with 110 beats per minute. BP was 150 by 80 and peripheral pulses were palpable.
Okay.
So because of the hypoxic, because of the breathlessness, it can be attributed he was being tachycardic.
Correct.
No specific intervention for the tachycardia part. And then we asked for the ECG. And next, coming to the disability.
If ECG, you are asking what in ECG are you looking for?
Is there any arrhythmia?
Okay. Arrhythmia is one thing because especially if this is a what patient? What respiratory? COPD.
Arterial and
No,
COPD.
COPD patient. COPD patients have high risk of MAT, multifocal atrial tachycardia. So it can be a MAT that you are seeing, or it can be AF also. So COPD patients has more potential to develop MAT or AF because enlarged
atrium.
left atria.
Left atrium.
Isn't it? Enlarged, not left atria, right atria. Sorry, my mistake. Right atria enlargement is there because of cor pulmonale. Because of that, they can develop arrhythmias. So if you are taking ECG, that is one thing. What else?
I think we can look for MI.
It can be MI. This is 65 plus years old patient. We don't know whether patient has CAD history. Even if patient doesn't have CAD history, right now he is in acute stress. His heart rate is high, his BP is high, he is having hypoxia. All these things can initiate a acute MI. So any acute STT changes, be it ST depressions or ST elevations, we should look. But ST depressions, it can be strain pattern also. If patient is having left ventricular hypertrophy, if ST depressions is only in lateral leads, it can be right induced strain pattern also. But we should take a ECG to make sure there is no cardiac components that we are dealing with. That
then coming to the next disability wise, patient was GCS was E4 V5 M6. Pupils were bilaterally reactive. He was oriented to the time.
Conscious oriented. That's the first
oriented.
thing. Conscious and oriented. Obeying commands. That's the main thing we are suspecting here, right? We are not suspecting a CVA or anything like that here. Then what?
Conscious oriented. Yes. And
Exposure. Anything in E, exposure you want to do.
Exposure, temperature we want.
Yeah, you need to see whether patient is febrile, right?
Yes,
it can be infection causing. So patient's temperature should be assessed and patient should be covered up. So if it is bronchial asthma, it can be triggering by the cold environment in our ER and ICUs, right? Yeah. So that's your primary survey, right?
Yes.
Yeah.
So again now
Reassessment. Come.
So the saturation, he was still being tachypnic and so rate still 35 per minute and saturation is still being 90% only. So right now we are auscultated back again and there is because of the bronchodilation initiation, there was the wheeze sound, quality of wheeze sound has increased. So earlier we can say that it was almost looking like a silent chest. Now it's getting better.
Yes. So what is a silent chest?
When we have
severe bronchospasm causing very decreased air entry so that we are not appreciating air entry into the chest. Patient will be extremely tachypnic but chest will be near silent, isn't it? Yeah, that is the worst kind. So right now you are saying that in comparison to initial time you are much able to appreciate the wheeze. So you are saying that air entry has improved, right?
Improved.
Yes, fine.
So, but the tachypnic
He's still persisting
and he's still using the accessory muscles. To ease his accessory muscles, we went to put him on the NIV.
Okay. And what was the APG? You got the ABG, no?
Yes, sir.
Yeah.
The ABG wise, the pH was 7.37, and
So no acidosis as
no
such.
acidosis. PCO2 was 47.1,
Okay.
and PO2 was 52.8.
Okay.
Bicarbonate 26.5. So PCO2 is elevated. So it would be a type 2 respiratory
Yes, so
failure.
this
And
is
there
a-
is this bronchoconstrictor, retention of the carbon dioxide.
Correct. So this is a type 2 failure. Even though it is only 2 points elevated from 45, any PCO2 retention should be taken as type 2
Type 2
failure.
failure.
So what do you think from this ABG? What are you dealing with? Are you dealing with the acute cause? Are you dealing with a chronic cause? What is it?
Acute because the bicarb there is in the normal, within the normal range, so it should be an acute type of respiratory.
Yes. According to the ABG, it looks like acute type 2 failure caused by obstructive airway disease, right? Because bicarb is not elevated. If it was a COPD patient, there would have been CO2 retention causing metabolic compensation, right? So bicarb should have been on a higher side. But not always, it can be on the lower side also, because especially if the patient recently started having COPD diagnosis and not much of CO2 retention has been documented, bicarb may be on the lower side. But there is type 2 failure, and that type 2 failure should be kept in mind. And whether bronchial asthma or COPD and all, we need proper history. Right now, since patient is in severe distress, we are doing emergency management. Okay, so we got the ABG. Now you told NIV.
Yes, sir.
So why do you want NIV for this patient?
To reduce the
Do you think for support of patient's respiratory effort is the correct answer for NIV or something else?
to maintain the saturation.
No. For this patient with your current values.
To remove the carbon dioxide.
Not to remove only, man. To prevent the impending respiratory arrest. So you say this is an acute type 2 failure. That means that we are dealing with a severe or fatal bronchial asthma. Bronchial asthma has fatal bronchial asthma, severe bronchial asthma, moderate and mild. These are the classifications. One of the criteria for fatal bronchial asthma is
CO2 retention.
CO2 retention. So if you say this is obstructive airway disease, COPD, bronchial asthma, whatever. If bronchial asthma, we are looking at a fatal bronchial asthma. So we need to support patient's breath so that he doesn't go into impending failure. Since features of that is there, we should start him on NIV. Okay. So you are starting the patient on NIV. Fine. So what NIV values do you want to keep in this patient? What is NIV settings will you ask your staff to keep the patient on?
We will ask like the expiratory pressure, we want to keep the baseline expiratory pressure as the normal expiratory pressure. The inspiratory pressure should be higher.
Yeah, so you have the inspiratory pressures and the expiratory pressures, right? So you have the expiratory pressure is as equal as a PEEP, isn't it?
Yes.
But since it is acute exacerbation with bronchospasm, you don't want a higher PEEP in this patient. Since you don't want higher PEEP, you will keep that on the lower end and give higher inspiratory pressure so that patient will have adequate support from the NIV for inspiration, and it will help the patient to take in much more better tidal volume, and CO2 washout can be promoted. So baseline NIV starts at what pressures? What is the baseline NIV? 10 is to 5. 10 is to 5 is the baseline. So we don't want much PEEP here. We can keep the PEEP at or expiratory pressure at 5 itself and increase the inspiratory pressure from 10 to maybe 12 or 14 to support the patient's need. We can start at 10 and slowly progressively increase according to patient's demand. We can increase that. How much FiO2 will you keep in NIV? Do you want oxygen here? If you want, what is the target? Saturation wise?
We would be targeting about 94%.
At 94%. Up to 94% is our target. Okay. So, be that NIV, you must have seen there are two modes, right? NIV mode is there and NIV ST mode is there. What is NIV mode and what is NIV ST mode? What is the difference between that?
Full control over the
What is ST mode means?
Spontaneous.
Spontaneous?
Trigger.
Yes, spontaneous triggered mode. So NIV mode and NIV ST mode, the difference is in ST mode, we can set a pre-limit of respirations that can be given with NIV. But in NIV mode alone, patient is triggering and taking his own respirations. So if this patient is actually triggering by himself and maintaining his breathing pattern, we need to support him only. We need not give more predetermined respiratory rate from ventilator, which will eventually clash with patient's inspiration expiration cycles. So ideally this patient should not be kept on NIV ST mode, it should be on NIV mode alone. We should not put a rate on the NIV for this patient. Okay, so you will start the patient on NIV. Okay, then what else?
And at this point, like still continuing the bronchodilators for further till as the wheeze is still audible.
Okay, okay.
Then coming to the secondary survey that is stabilized, like primary.
What else? Primary survey have adjoints, right?
Yes, sir. The ABG and the CBC CRP point of care and ECG.
CBC CRP point of care, not everywhere it will be available. You will send blood parameters to rule out infection. Isn't it? Yes. And what else? What else is the one thing you need to rule out here?
ECG.
What are
X-ray,
the most
chest
common causes, most common and most life-threatening causes of acute breathlessness? Pneumothorax. Then?
Pulmonary embolism.
No, pulmonary embolism. Patient with acute breathing difficulty.
Pulmonary edema.
Pulmonary edema. And this thing, bronchospasm, obstructive airway disease, and one more, pneumonia. Patient can have bilateral pneumonia, ARDS. So we have an infective cause. We have pneumothorax. Then we have airway obstruction. These are the one of the three main respiratory components. If we take out cardiac pulmonary edema and all comes now. So what I'm saying is a patient with acute breathing difficulty when they present and you are having wheeze, don't just think it is COPD or asthma. There can be other conditions also. One of the things that you should think about is a cardiac component to this. Cardiac MI causing pulmonary edema should be suspected. Similarly, it can be pneumothorax. So any history of pleuritic chest pain or asking even the patient, you can ask just chest pain or not. Patient can say yes or no, right? You don't want a detailed history. Any one-sided chest pain is there, you should suspect pneumothorax in this patient. It can be otherwise when you are examining the patient is having so much coughing, patient is pulling out stool and sputum. It can be bronchiectasis or it can be pneumonia, isn't it? And of course, it can be bronchial asthma. So these things we should be kept in mind. So you need a chest X-ray here. For what?
See the lung.
Mainly for what?
Pneumothorax.
So think that you are unable to get X-ray. There is no portable X-ray available. What will you do?
Ultrasound.
Yes. In our institution, we can use ultrasound to find pneumothorax. Not everywhere. Everywhere ultrasound may not be that much easily available. But if available, ultrasound should be used. If you use ultrasound, how will you identify a pneumothorax? Or how will you rule out a pneumothorax? That is much more easier.
Presence of lung sliding.
Yeah, that's very easy to say, but you should tell. When people are hearing, they will not understand how you found out lung sliding. No, you should use
The
vascular probe. You should use a linear probe or a vascular probe which has high frequency, so much better clarity. Because we are looking at a pleura that is lying just below our chest muscles, right? We don't want much depth there. So no abdominal probe, it's a vascular probe, linear probe, and we keep it on the
4 anterior, 2 lateral and 4 posterior.
Yes, so basically we have 10 segments in each lung field is there. We are supposed to screen all areas. It is not there is lung sliding present in mammary area, so it is fine. No, it's not like that. We have to screen all lung areas. So ideally, it should be done on a sitting patient or a 45 degrees head and elevated patient, supine patient. We wouldn't be able to do it on the posterior aspect, isn't it? So we can do it in the mid-clavicular line going down and on the axial region. What are you looking for? Normally, what will you see?
The whitish, bright white
Pleura.
line of pleura moving along with the respiration.
So with each respiration, the parietal and visceral pleura will be rubbing each other, isn't it? So you can see that rub as a constant movement between pleura in ultrasound. If there is pneumothorax, yes. Since air is between the pleura, there won't be any rubbing of pleura. Since no rubbing of pleura, you will not see the movement of pleura. So absent lung sliding, it's very difficult to say as such, we know, but since we are in this class, absent lung sliding should be taken as a possibility of pneumothorax. No, may not always be pneumothorax, but possibility of pneumothorax. So in this patient, if we can get lung sliding in all areas, we can literally rule out pneumothorax. Okay, so if X-ray takes time, you can opt for a ultrasound to rule out pneumothorax. Okay, then what else? Secondary survey.
So regarding this, the patient is a known case of hypertension, dyslipidemia, previous right-sided hemiparesis stroke, and status.
When you say stroke, it should always be either ischemic or hemorrhagic. It is not right-sided stroke. It is which area of the brain had stroke. So this is left MCA, ACA, PCA, whatever. Okay, do not say right-sided hemiplegia with stroke. Ischemic CVA or hemorrhagic CVA with affected area. That's how you should say. And you can add that whether persisting or resolved weakness is there. Okay.
Patient had left-sided MCA infarct 10 years ago with causing right-sided hemiparesis at the time, but now it has been resolved. And he is also having coronary artery disease of triple vessel disease, status post PTCA to the primary thrombo artery done to the LAD. And he is having a chronic...
But not a CABG patient.
Not a CABG patient.
Okay.
Chronic right-sided lower limb edema he is having, status post recurrent cellulitis to the right-sided lower limb.
Lymphedema.
Lymphedema is there.
So it's a non-pitting lymphedema.
Non-pitting lymphedema is there. Present, coming to the present event, patient has been attending his grandson's wedding. So he has been in the AC room for the last few hours, during which he had developed sudden severe breathlessness. And he was using the inhaler which was provided to him for asthma.
Okay.
Even after taking multiple puffs of that inhaler, he has not the respiratory distress. There was no relief. In view of that shortness of breath, he has been brought to the emergency.
Okay. Okay. But this is a very short history, right? They are saying that patient was apparently normal and only in the event patient became breathlessness. There is no history of fever, no cough, no sputum production.
Further, like examination, the past history was patient was having a history of fever 3 days ago, which was relieved with taking tablet paracetamol.
Okay.
And it wasn't persisting, only one tablet he had taken and it has relieved it.
Okay. After that, he didn't have any breathing difficulty at all.
It was not associated with breathing difficulty. It was associated only fever and mild cough.
But after paracetamol, no fever.
No fever.
Okay.
That was the history part, sir. And on the examination part right now, the patient is conscious, oriented to time, place, person, and GCS being full 15/15. And
but in the meantime, see. Here, history-wise, of course, we told there is no, there is a history of fever, but there is no breathing difficulty associated. But that is one of the criteria, right? That is the infective criteria. We have to ask about chest pain. This patient, we don't know the diagnosis, right? So we have to think about respiratory system as well as cardiac system. It can be pulmonary edema also. Early pulmonary edema, early acute pulmonary edema can present like acute wheezing also. It can progress to crepitations on a later stage. So we have to think about orthopnea, we have to think about PND, exertional dyspnea, exertional angina. These histories we need to ask for him. Similarly, especially he is a triple vessel disease patient, only stented in left anterior descending, two other culprit arteries are left free. It can be acute MI, isn't it? And he is in a function. Emotional liability is also something that can cause acute MIs. So we should suspect MI here. So that history we should ask.
No
Pre-syncope,
history of
chest pain, chest tightness, chest heaviness, any pain on the neck, back, epigastric pain. All this is important in here. So do not think that we got wheeze, it is pulmonary case. Wheeze can be a part of early pulmonary edema also. So we need to ask that. Similarly, pneumothorax, especially if he has a smoking history, whether he is on chronic MDI inhalers. If he is on chronic inhalers, we can think whether he is on non-case of COPD patient or non-case of bronchial asthma patient. Bronchial asthma patients with a history for this, it's very important. We need to ask them, does this patient requires multiple hospital admissions in a year due to breathing difficulty? If yes, the question will be whether the patient is on steroids or whether the patient is on antibiotics. If the patient is on steroids post hospitalization and sent back with steroids, most probably this patient is having bronchial asthma. Glucocorticoids is one of the mainstay of treatment for bronchial asthma, right? But patient is getting multiple episodes of hospitalization almost every time with infections. Patient is on chronic antibiotic therapy. It can be bronchiectasis, it can be COPD, all these things. So this is very important. Okay, as emergency physician should not be just for symptomatic management of acute presentations and giving the patient to some other department. We should have a clear-cut diagnosis of what is happening with the patient. Especially in here, we have two different systems, cardiac versus respiratory. In respiratory itself, what is happening? We should get that history. Okay.
So the patient had no complaints of any chest pain previous on acute onset chest pain or any previous palpitations, syncope, dizziness or any history, sir. And he's also been using this. There is no any previous admission to hospital in view of the breathlessness for the last 1 year. Before the last hospital admission was before 1 year.
Okay.
OPD visits, not like any hospital admission at all. Never in his
Not
life.
at all. So he is, even if he is having breathing difficulty, it's a well-controlled breathing difficulty, isn't it? Is he on any inhalers?
Yes, he's a known case of asthma. As per the bystander, he's a known case of asthma since childhood. He was using regular inhalers he was having.
So now we have got a clear history. It's a known case of bronchial asthma on inhalers, currently presenting with acute exacerbation. Most probably the
Yes.
occasional that hole containing AC and L must have triggered it off. Okay.
Then the examination. Examination part, patient regarding the respiratory system. We can say on inspection, the patient was using accessory muscles, and the trachea is central in position, and this
Why trachea central is important?
to see if there is any pneumothorax or if there is any
Pneumothorax.
fusion.
Fine.
And then on the palpation part, there is equal chest raise in bilateral side.
Good.
And on the auscultation part, the breath sounds were present bilaterally, but wheeze was present. Bilateral wheeze is still persistently present. So.
Any crepitations?
No crepitations. So so we are diagnosing this as a severe exacerbation of the asthma.
Okay, but in cardiology also,
Cardiology.
we already covered, no? Cardiology also, you need to see any murmurs.
No,
Basically, only murmurs you are going to find out, no?
Yes.
S3, cardiac failure, S3 and all, we can theoretically say, but it's very difficult in emergency department to get a S3 and all. practically speaking. Theoretically, of course, you should look for S3, elevated JVP, all those things are there. Elevated JVP, we can even look here, but bronchial asthma, especially
No
if there is a
bilateral pedal edema.
bilateral pedal edema, elevated JVP, we can look into that. And murmurs, patient not a known case of murmur, currently having a murmur, we should suspect a recent MI. S3 might be difficult, but other things we need to look. Okay.
So then impression would be the severe exacerbation of asthma.
Okay. So, fine. What is the classification? We already told. Asthma has four classifications. Mild, moderate, severe,
fatal.
And fatal. Yes, life-threatening. Either life-threatening in certain books or fatal in certain books. Fine. So, it's very important that we differentiate between these, right? How will you differentiate?
Depending upon this treatment, actually response to the treatment.
Oh. Treatment is given according to how the patient presents, right?
Duration, episodes of symptoms, and the FEV1 by FVC ratio. FEV1 by FVC.
FVC. What is FVC?
Force expiratory.
Force expiratory?
Volume.
FEV.
FEV1 by FAC.
So, how will you assess?
Spirometry.
So, you'll ask the patient to do spirometry? See, don't just say what is written in textbook, think.
Initially, we will give a bronchodilator and first we need to confirm it is an obstructive or a airway inflammation. And if there is improvement after bronchodilator more than 12% improvement or more than 200 ml.
How will you know he improved? Spirometry, right? So you need a first spirometry, right? See, what you are saying is correct. I understand that Harrison is written, we should do FE1, correct. Maximal expiratory flow should be assessed in patients who can do that, not for everyone. So you need to make a judgment call which patient is able to do FEV and who will not be able to. That is very important. We told mild, moderate, severe and life-threatening. So the criteria will be to identify severe and life-threatening patients. Mild and moderate, we can use these procedures. Okay. So how will you say a patient is in severe bronchial asthma or life-threatening bronchial asthma?
Saturation.
Yes. So life-threatening has mainly 2 to 3 criteria only. One is PCO2 retention. So patient has acute PCO2 retention. You should suspect the patient is in life-threatening asthma. Second thing is patient is having altered mentation. Acute altered mentation, that word is very important. See, a patient can be in altered mentation due to multiple causes. Patient can be hypoglycemic. Patient can be having hyponatremia for last 3 days. Okay. So the altered sensorium should be very acute after the onset of breathlessness. Okay, then only we can say that is hypoxia induced altered sensorium. Okay, so don't say all altered sensorium patients is in severe failure. Okay, so altered sensorium, PCO2 retention, and Western guidelines say that oxygenated patients on 3 to 4 liter oxygen, supplemental oxygen, not able to maintain 90% saturation. They say it as criteria, but practical levels we have always seen patient coming back with proper bronchodilation, even with saturation less than 86%, right? So that saturation part, I think it's better to look at a judgmental view rather than a criteria view, because if we do criteria, then most of the patients presenting to our ER will require intubation. So don't do that. But this is one thing you need to identify in acute presentation patient, life-threatening. Now coming to severe bronchial asthma. What is the general features of severe bronchial asthma?
Increased respiratory.
Yeah. How much?
More than 30.
Yeah. So respiratory rate more than 30.
And then the SpO2 less than 90 to 94.
Yeah. SpO2 less than 90 in non-oxygenated patient. That is in room air less than 90%. That's very important. The other one is with oxygen. This is without oxygen. Then tachycardia. Heart rate more than 120 is a direct indications saying that patient is in respiratory distress or severe bronchial asthma, heart rate more than 120. Then theoretically we have all heard that part. Next one criteria, theoretically.
FEV1 by FEV2 less than.
No,
Expert.
no, theoretically. Pulsus paradoxus. What is pulsus paradoxus?
During inspiration, the fall of BP more than 10.
Systolic BP.
More
Don't
than
be
systolic.
fall of BP. Very specific. Systolic BP more than 12. More than 12 millimeter of mercury fall is there. We can say that is pulsus paradoxus. Theoretical, very difficult to do in ER, but that is a criteria to say severe bronchial asthma. Of course, as you told, FEV criteria is there. So, what is the problem there? Problem is, first of all, we should know what is the personal best expiratory value of that patient. So if patient has already done a spirometry study in your institution, or they have a report of spirometry study that shows FEV value, you know, okay, this patient's personal best FEV is dash liters per minute. Fine. But if that is not there, how will you know? You will not. So you need to look. So there are some charts are there which shows values. The problem is FEV is not fixed. It varies with age, sex, height. So very varied. But you can use certain charts that shows. Basically, FEV less than 50%, we can say it as severe. So usually it is less than 200 liter per minute. Usually, because around 400 something around is age more than 65, around 400 minimum should be there. So less than 50%, less than 200. So less than 200 is there, you can. But you can't expect a severe breathing difficulty patient who is breathing at 30 breaths per minute to sit up and do a FEV study. So you start management and see whether patient worsens or improves. If patient worsens, you don't look at FEV and all these things and you manage the patient. If he improves, then post-improvement, we can see his FEV. And if FEV is more than 50% or more than 80%, more than 80% is actually improvement. You say that good improvement is when more than FEV, more than 80% of predicted. And this predicted is what we say as 400. So at least 80% of 400 he is meeting, we can say good improvement. More than 50 but less than 80, we say it as ongoing improvement, and we requires the patient to be further evaluated or observed and treated and all these things. Okay, fine. So that is FEV. But the thing is, don't expect all patients to do FEV. Do not ask a severe or life-threatening patient to do FEV. That is not a criteria. It's mild to moderate. No. Now, severe. This is anyhow life-threatening, right? You started NIV, good management. You started NIV, you are giving a trial. What else? What else will you do here for this patient?
We can start with additional bronchial, like
bronchodilators, short-acting beta agonists. That is the management. Okay. How much? How will you give? How much?
The initial would be the giving beta agonist, short-acting beta agonist, salbutamol, 2.5 mg per per cycle. Every cycle repeating it continuously. As this is severe, we can repeat till 1 hour continuous cycles.
So that is known as stacked nebulizations. You don't give a break between nebulizations. You are continuously giving nebulizations. Stacked nebulizations. That is usually not possible in our nebulization mask. You need a NIV to do that, or a ventilator to do that. There is a nebulization option in NIV or in ventilator. That is how you can do stacked nebulizations. Okay. So you can give around 10 times the normal value with stacked nebulizations. That is possible. You can do that. Otherwise, in a normal setup, how much will you give?
For cycles?
6 times.
6 times.
6 cycles of nebulization is what you give. Okay. Nebulizations. Now, you give nebulization with nebulizing mask, right? Why not MDI? Why not inhaler? Patient already is on inhaler. He has inhaler.
But
Why not give that?
humidified air to,
Why you want humidifier air?
so that it will be dilated.
Humidifier air dilates bronchus. Come on. Why you want nebulizer? Why can't MDA?
We can.
You can or can't? You can.
Can.
You can. We use nebulizer mainly because it is readily available. All hospitals have nebulizer. Second thing, life-threatening asthma and severe asthma patients is having respiratory distress. Most of them will be agitated. Most of them will be diaphragmatic. They will not be sitting there to obey instructions. So you ask them to take a deep breath, then breathe out, then take a puff with the MDA and hold it for 30 seconds. They can't do that. They are extremely breathless. Okay, that is the reason why we give nebulizations with nebulizing mask. But any patient with moderate to mild to moderate bronchial asthma exacerbations, it is best to give MDIs, metered dose inhalers, rather than nebulizing mask. And if patient is having breathing difficulty, but not in distress, but breathing difficulty, you can ask them to put a valve-based container. We have the mask, right? Inhaler with mask. So that you can use. So there is a valve. You know the pediatric inhalers, right?
Yes.
Yeah. So there is a one-way valve. So you put the metered dose on one side, you press it, the medicine is inside the container, and whenever patient inhales, it goes in, and when patient is exhaling through nose, the valve is blocking. It's a one-way valve. You can use this. So it will negate patient's respiratory distress part, but mild to moderate. In severe, patient will not be able to correspond to these instructions. What is problem with nebulizing mask? Lot of leakage, and the particles produced is big size. Aerosoled inhalers are aerosoled particles. It's very minute. So better drug delivery is there. Nebulizations is using water as a conduct, right? So it has bigger particle sizes which may not reach the targeted area. But since readily available and difficult to administer is the hindrance to this. Okay. So you start short-acting beta agonists. Then what you will add along with it? In acute, steroids. What is the dose of steroids?
Steroids, we start with this dexamethasone 6 mg.
You can start hydrocortisone, dexamethasone,
Hydrocortisone
doesn't
150
matter.
to 200 mg or dexamethasone 6 mg.
6 mg, methylprednisolone 1 mg per kg. 1 mg per kg you can give intravenously. If it is mild to moderate, even orally is fine, because steroid is not going to act then and there. It is going to act in next 4 to 5 hours, isn't it? So we are looking at controlled further control rather than acute control. Okay, so mild to moderate oral glucosteroids, severe to life-threatening IV steroids. What else?
Further, we can go in with the anticholinergic.
Magnesium sulfate.
Muscarinic acid.
Muscarinic agonist.
Inhaled muscarinic agents. Ipratropium. Isn't it? Yes. Ipratropium we can add. What is the dose?
Ipratropium we give like 500 micrograms in like nebulization form, or we can give in.
You can give in MDA also.
MDA.
Okay. Dose of inhaler. If you are using MDA in mild to moderate, it is 4 to 8 puffs. In mild, you can put 4 puffs. Moderate, you can put up to 8 puffs in a single time. Wait for 20 minutes, then repeat this. Okay, so 4 to 8 puffs every 20 minutes is what we can do in MDA inhalers, metered dose inhalers. If nebulizations, as we told, 6 times the dose we can give. 6 cycles of dose, normal dose we can give. Okay. So, short-acting beta agonists, short-acting muscarinic agents, glucocorticoids, then O2 to titrate saturation between 90 to 94%. Anything else?
Magnesium sulfate.
Magnesium sulfate. Is magnesium a proven drug for acute bronchospasm? It's not proven. All meta-analyses have shown that it doesn't have any improvement other than a placebo effect. But theoretically, it prevents calcium influx to bronchial muscles from dilation. But you can give magnesium 2 gram in 100 ml IV over 20 to 30 minutes. Okay, fine. What else?
Next, we can even try with ketamine.
Yes,
Severe
nebulized ketamine is currently not recommended anywhere. There is no guideline. There is nowhere recommended that ketamine should be used. That has to be told first. Whenever we say experimental things, should be very clearly mentioned. It's experimental. But there are multiple hospitals in US that use nebulized ketamine in acute bronchospasm patients. Do you know why?
Why is yes.
More than reduction in bronchospasm, most of the acute bronchospasm patients will be highly anxious, agitated, anxious. They will be very tachypneic and they will be having very short rapid breath, right? Short rapid breathing is actually worsening them because they need more expiratory time. So the more the respiratory rate, less the expiratory time, which will worsen them more. But we can't sedate them. We can't give them benzodiazepine because we give them benzodiazepine, they may go into respiratory depression or decrease sensorium, causing less respiratory drive and can go into hypercapnia, recurrent ventilation. So benzodiazepine is not a good drug for acute bronchospasms. But nebulized ketamine can cause theoretically bronchodilation. But there are studies that compared it and told that patient becomes much more less anxious and much more receptive of our advices and our instructions. So is possible, not a mainstay of treatment, just experimental. So that should be very clearly mentioned there. Nebulized ketamine is not a mainstay of treatment. Nowhere it is written that it should be given. Okay, and ketamine is not a simple drug. It's a very, very dangerous drug. It should be used with extreme caution. Okay. Anything else?
Anything else, sir? Like
when will you intubate? Emergency medicine. The question is, when will you intubate?
It's not.
Yes, NIV trial. NIV trial fails. So maximum 2 hours is the time. You can repeat ABG. If PCO2 retention is worsening, intubate the patient. Or if patient is in life-threatening respiratory distress, not at all very anxious, very agitated, not at all ready to cooperate with for NIV treatment, intubate the patient. That criteria should be very clear. And once patient improves, we can de-escalate the treatments and even de-escalate NIV. There is no requirement for NIV weaning and all. You can stop NIV and start the patient on meter dose inhalers. When will you discharge acute exacerbation patient? Not this patient. This patient requires admission. Like a mild acute asthma presented to you or moderate asthma presented to you. You treated for 2 hours, 3 hours, patient improved. Right now patient is FE1 is more than 80% of predicted. Saturation is 98 on room air. Very mild bees. Your CBC CRP is showing no acute infections. Will you discharge the patient?
We can
You can discharge. You should discharge. There is discharge criteria. These are the criteria that meet discharge.
Mainly the PEF, like for the discharge criteria, getting improved.
Yeah, so that's one. FEV more than 80% of predicted. We can plan for discharge. What will you give the patient when you discharge?
We can give oral steroids.
Yeah, you should start the patient for oral steroids. At least for 5 days, oral steroids should be given 1 mg per kg, either in single dose or divided dose, but oral steroid should be given. If patient is having history of more than 1 week, 2 weeks history before coming to you is there, or multiple histories for past 1 to 2 months is there, you can even think about chronic maintained dose glucocorticoids. You can plan. That's it. Anything else?
Nothing.
If this patient has pneumonia, what is the drug of choice? What is the antibiotic of choice will you start? This patient has pneumonia. You took X-ray shows right-sided pneumonia.
We will go with the community, most likely community acquired pneumonia, so ceftriaxone would be the...
Yeah, so it's a community acquired pneumonia. We are looking at staph, strep, hemophilus. This is what we are looking at. You will start a gram-positive coverage. What is the least gram-positive coverage you can start? Fluoroquinolones is one thing associated with this is a 65-year-old patient, no? So atypical organism should be suspected. Azithromycin. A fluoroquinolone with macrolide is one option, or
covering all like
Piptas. We want to start Piptas in this patient. Augmentin with a macrolide. Either a augmentin with a macrolide or a fluoroquinolone with a macrolide is a good choice for this patient. Especially if you are planning to discharge a patient, not this patient, a patient like this after 24 hours of admission, augmentin with macrolide, fluoroquinolone with macrolide, or else you can just start ceftriaxone. Third generation cephalosporin alone is good enough. Okay, if it was a young patient, no need of macrolide. That's it. Okay. Anything else? Any doubts? Any questions?
Nothing.
Thank you.